All right, so what are we going to see in a typical brainstem vascular syndrome? And this point is made quite nicely in the text on the next slide. Number one, it's virtually impossible, or uncommon anyway, to lesion injure parts of the brainstem without involving one or more cranial nerves, since we have cranial nerves coming out medially and laterally out of the midbrain, various parts of the pons, and the upper medulla. Secondly, if the lesion is inside the brainstem, obviously we can lesion cranial nerves outside the brainstem. If the lesion is inside the brainstem, it's very difficult to have a brainstem lesion that doesn't affect one or more of our major neural system tracts, including corticospinal tract, the medial lemniscus, or the spinal thalamic tract. And as we know, if we lesion the spinal thalamic tract, we're also likely to lesion the descending hypothalamic fibers and get Horner syndrome. Also, recall from our review of brainstem sections that the long tracts occupy different positions as they run through the brainstem. As we said, the corticospinal tract always coursed medially. The spinal thalamic tract was always in a lateral position, so they're going to be affected by vascular syndromes in those various territories. But the medial lemniscus changed its position, starting out medially in the medulla, coursing to a lateral position as it finally reached in the midbrain. And as we know, a lesion of any one of those three, corticospinal, medial lemniscus, or spinal thalamic, will cause a deficit that is contralateral and below the lesion. And the only added feature to that is the descending hypothalamic fibers. We know that they course laterally through the length of the brainstem near the spinal thalamic tract, and when lesioned, they will result in an ipsilateral central Horner's syndrome. So with that in mind, let's now look at various commonly tested brainstem lesions in the medulla, pons, and the midbrain, beginning with a medial medullary lesion that, as we predicted, is going to have one or more long tract signs that could be lesioned anywhere in the brainstem, but what will localize the lesion for us will be the cranial nerve sign that is also present. So in a medial medullary lesion, we actually will have commonly two long tracts affected. The corticospinal tract, which is always present in any medial lesion, but also we lesion the medially positioned fibers of the medial lemniscus, both of them resulting in contralateral long tract deficits. What localizes the lesion to the medial medulla is the lesion that also includes the exiting fibers of the hypoglossal nerve. So medial medullary syndrome presents with the following: a contralateral spastic weakness because of involvement of the corticospinal tract or medullary pyramid, a contralateral loss of touch, vibration, pressure, and proprioception as a result of a medial lemniscus lesion. What localizes the lesion to medial medulla are the lesioning of the exiting fibers of the hypoglossal nerve, where because of that, the patient will have tongue deviation toward the side of the lesion on protrusion, but certainly the tongue weakness will be contralateral to the spastic weakness in the limbs because cranial nerve deficits are ipsilateral and long tract signs when lesion in the brainstem are contralateral. Again, cause of this lesion, an anterior spinal artery vascular occlusion. Next, we move not out of the medulla, but instead of lesioning the medial medulla, now we're going to lesion the lateral medulla. And this is a classic, frequently tested series of signs and symptoms. But fundamentally, if you strip it all away, it's just a long tract sign that's co-localized with a cranial nerve sign. So in reality, you only need the two signs to localize this lesion. First point is, out in the lateral medulla is where we would find the spinothalamic tract. So this patient, in terms of a long tract sign, is going to have a contralateral loss of pain and temperature in the limbs and body. And as we know, since the descending hypothalamic fibers run adjacent to that spinothalamic tract, this patient is likely to have an ipsilateral ptosis, meiosis, and anhydrosis, Horner syndrome. The cranial nerve that is exiting out of the lateral medulla, there are actually two, one more significant than the other, are cranial nerves 9 and 10. 9 basically less significant, but when cranial nerve 10 is lesioned, particularly its skeletal motor fibers, this lateral medullary patient is going to have a combination of palate weakness, pharynx weakness or larynx weakness, probably a sign or a symptom attributable to all three. Drooping palate, dysphagia, hoarseness, fixed vocal cords, some combination of those three instantly localizes a lesion to the vagus nerve, and now we have enough information, a cranial nerve and a long tract, to localize a lesion specifically to the lateral medulla, which is the exit or entry point of vagus nerve fibers. But the story doesn't end there, because look what else is situated out in the lateral medulla, the spinal nucleus and tract of 5. So this patient is likely to have a contralateral loss of pain and temperature from the limbs and trunk, but they're also likely to have an ipsilateral loss of pain and temperature from the skin of the face, on top of the signs and symptoms of Horner syndrome that we've already indicated might be present also ipsilaterally. So that's an additional feature that could be evident in lateral medullary syndrome. And then patient might have auditory problems, maybe even a nystagmus because of the presence of the vestibular and or the cochlear nuclei. And also, if the inferior cerebellar peduncle is involved, it's associated with cerebellar function. The patient won't have any limb weakness, but they might have an ipsilateral ataxia because of the inferior cerebellar peduncle involvement. So there are lots of things that are associated, as indicated on this list, with lateral medullary syndrome, but fundamentally, you can localize this lesion just on the basis of two features. One, the lesion of the spinothalamic tract, giving us a contralateral loss of pain and temperature in the body. And number two, the involvement of the fibers of cranial nerve 10 whose axons are coming out of the nucleus ambiguus and are providing the lower motor neuron innervation of skeletal muscles of the palate, the pharynx, and the larynx, and some combination of signs and symptoms attributable to weakness in that area. But again, as we've illustrated, if you lesion the spinothalamic tract, you may also have a patient with ipsilateral Horner syndrome. You're going to have what is known as a dissociated pain and temperature loss in this patient because you will have a contralateral loss of pain and temperature in the limbs and body, but you may also have an ipsilateral loss of just pain and temperature in the face. All of the other modalities associated with the trigeminal nerve, motor, and sensory will be intact. And again, because of the adjacent vestibular nuclei involvement, we might have vestibular signs and symptoms and or even cochlear signs and symptoms because those sensory nuclei are situated in the area of the lateral medulla. And then finally, there won't be any limb weakness, but there may be some ipsilateral limb ataxia because of the involvement of the inferior cerebellar peduncle. And classically, this is a vascular insult of posterior inferior cerebellar artery that results in lateral medullary or Wallenberg syndrome. Now, moving rostrally, what's going to be different about a patient that has medial Pontine syndrome, and how do you know the lesion's in medial pons and not in medial medulla? Because look at the two long tracts that are involved again as they were in medial medulla. Medial lemniscus and corticospinal tract. So again, the patient's going to have a contralateral spastic weakness and a contralateral loss of touch, vibration, pressure, and proprioceptive sense. What localizes the lesion to medial and caudal pons is the involvement now of cranial nerve 6 as opposed to cranial nerve 12. So this patient is going to have basically a strabismus instead of the tongue weakness that we saw in a corresponding lesion in the medial part of the pons, or the medial part of the medulla, excuse me. So again, here's the story. Same long tract signs as we saw in medial medullary syndrome, but now because of the fiber involvement of cranial nerve 6, instead of having tongue weakness, we have an internal or a medial strabismus because we've lost the ability to abduct an eye on a corresponding side. But again, same pattern. Two long tracts in this case with contralateral body and limb deficits. The localizing feature to medial Pontine syndrome are the fibers of involvement of cranial nerve 6. Our next case is a lesion of the lateral part of the pons, and in this case we're going to have some of the same involvement of the neural systems that we saw in lateral medullary syndrome. What's going to be different is we will have different cranial nerve involvement. So again, lateral brainstem lesion is going to affect the spinothalamic tract, giving us a contralateral loss of pain and temperature in the limbs and trunk. Patient is also likely to have an ipsilateral central Horner syndrome because those descending hypothalamic axons are in the same position. In addition, the patient is likely to have an ipsilateral loss of just pain and temperature from the face because, as you can see in the picture, the spinal nucleus and tracta 5 are also involved. But what localizes this lesion to lateral and caudal pons are the fibers of 7 and 8 as opposed to the fibers of the vagus nerve, which localize the lesion to lateral medulla. So in addition to the long tract signs, this patient is also going to have facial muscle weakness. They're going to have, in essence, an ipsilateral Bell's palsy, and they may also have involvement of either the cochlear or the vestibular nerve fibers that are entering laterally in cranial nerve 8. So again, this is summarized on the next slide in text form, where again, the classic long tract with a lateral brainstem lesion is the spinothalamic tract involvement, giving us a loss of pain and temperature that's contralateral and below the lesion. That's at the top. Obviously, lesion together, because they run together, might be those descending hypothalamic axons. That'll give us ipsilateral Horner syndrome. We might involve, again, that spinal nucleus and tracta 5, giving us, again, the dissociated pain and temperature loss, ipsilateral face, contralateral body. But what localizes the lesion to lateral and caudal pons are the fibers of the facial nerve, giving us ipsilateral facial paralysis instead of the palate, pharynx, larynx signs we saw with lateral medullary syndrome. And again, because of the adjacent cochlear nerve, vestibular nerve, and or nuclei, we could have the dizziness, nausea, vomiting, and a vestibular evoked nystagmus, and or a profound ipsilateral sensory neural hearing loss because of the involvement of either the entering cochlear nerve fibers or of the cochlear nucleus itself. Vascular insult that causes this is commonly an occlusion of AICA, the anterior inferior cerebellar artery that's supplying the lateral and caudal pons. Good distinction to be made now is how is a lateral Pontine syndrome that involves the facial nerve going to be different than a pontocerebellar angle syndrome. This is a very good illustration of a lesion that involves cranial nerves, but involves cranial nerves only outside the brainstem. And the way you know it's outside the brainstem is because there are no long tract signs, no involvement of corticospinal, medial lemniscus, or spinothalamic tract. So pontocerebellar angle syndrome is classically caused by a slow-growing tumor that originates in the Schwann cells, commonly of the vestibular part of the 8th nerve, less commonly the auditory nerve. So the initial presentation in this patient might be dizziness, nausea, vomiting, and a progressive loss of hearing on the ipsilateral side. And because of the proximity, as the tumor expands, it next is likely to compress the fibers of the facial nerve that are exiting at the same point, causing an ipsilateral complete weakness of muscles of facial expression. And classically, as the tumor expands, it tends to expand up toward the pons, where it's likely to compress the fibers of the 5th nerve at its exit point from the rostral pons. But again, this is a classic example of the same cranial nerves being involved as in lateral Pontine syndrome, particularly 7 and 8, but because of the absence of long tract signs, the lesion cannot be inside the brainstem. It has to be outside the brainstem because it only involves cranial nerves and no long tract signs. Next, let's look at a classic midbrain syndrome. This is medial midbrain syndrome. Again, at face value, this is the simplest of the brainstem vascular syndromes because there's only one major long tract that's involved, corticospinal, because it's a medial brainstem syndrome. So the patient's going to have a contralateral spastic weakness. What localizes the lesion to medial midbrain will be the lesion fibers of an oculomotor nerve. So the patient is going to have a dilated pupil, ptosis, and an external strabismus on the corresponding side of the lesion. But that's not all. Recognize that if I have medial midbrain syndrome, I've affected not only the corticospinal tract axons in the middle of a cerebral peduncle, but I've also lesioned, as illustrated here, all of the corticobulbar axons on the medial part of a cerebral peduncle. So the issue comes up, what else is the patient likely to present with in addition to the oculomotor signs? And the answer is only contralateral lower face weakness, because as we know, the corticobulbar axons bilaterally innervate lower motor neurons and cranial nerves, except for the lower motor neurons that serve the contralateral lower face. So in addition to having contralateral limb spastic weakness and oculomotor signs, this patient is also going to have a contralateral lower face weakness. So in text form, here is a summary then of the neural elements that are lesioned in medial midbrain syndrome. Again, since it's a medial vascular insult of the brainstem, it involves the corticospinal tract, giving us contralateral spastic weakness in the limbs. The localizing factor in this lesion are the fibers of the oculomotor nerve, giving us the ipsilateral ptosis, dilated pupil, and external strabismus. But obviously, in addition to getting the corticospinal tract, since we are above the facial motor nucleus, we're also lesioning all of the corticobulbar axons, but the only sign we will typically see in the patient will just be limited to a contralateral weakness of the lower face. Then, the other brainstem lesion that's illustrated here is not a vascular one, but one that we alluded to earlier in our brainstem conversation, and this is a dorsal midbrain compression, commonly the result of a tumor of the pineal gland. And this results in what is known as Parinaud syndrome. And as we indicated earlier, we know that that pineal gland sits directly above the area of the pretectal region and the superior colliculus, such that a patient with Parinaud syndrome is likely to have a disruption or weakness of vertical conjugate gaze, and because of the compression either of the posterior commissure or the pretectal area, have a slightly suppressed pupillary light reflex. And finally, and you can see it here even though it's not labeled on the slide, if the pinealoma is compressing the area of the cerebral aqueduct, this same patient is also likely to have elevated intracranial pressure and a non-communicating hydrocephalus. So in text form, this is the point that we make here. When a pineal tumor compresses the area in, at, or adjacent to the superior colliculus, again, there's going to be a weakness of vertical conjugate gaze, a slightly suppressed pupillary light reflex, and because of the compression of the cerebral aqueduct, a non-communicating hydrocephalus. Now, good place to summarize lesion strategy for brainstem, which we've just completed, but also comparing that going back to what we see in a spinal cord lesion that involves our major neural systems, and what we're going to see with lesions of neural system elements that will be lesioned above the brainstem. So in this first view, we see, again, the locations of our fundamental neural systems as they exist at spinal cord levels. And again, what we're illustrating is the results of a Brown-Séquard hemisection that involves all three of them, the dorsal columns, the corticospinal tract, and the spinothalamic tract. So in the case, as we know, when we lesion all three, or even lesion them individually, at spinal cord levels, we have what are known as two ipsilateral long tract signs, ipsilateral below the lesion. They will be a lesion of the corticospinal tract, which will give us an ipsilateral spastic weakness, and a lesion of the dorsal columns, which will give us an ipsilateral altered vibratory sense, and only one contralateral sign. The single contralateral sign that's evident below the lesion, contralaterally, will be an isolated lesion that involves the spinothalamic tract. So again, we're going to see in this case, some of this is a spinal cord hemisection, results in two ipsilateral long tract signs and only one contralateral long tract sign, limited to loss of pain and temperature below the lesion. Obviously, no cranial nerve deficit will be seen unless the lesion is at cervical spinal cord in the area of the accessory nucleus. What changes now when we move to the brainstem, as we've just seen, is all of the long tract signs, regardless of where they are lesioned in the brainstem, result in deficits that are contralateral and below the lesion. The only so-called ipsilateral sign we might see with a brainstem lesion might be a Horner syndrome, because those descending hypothalamic fibers are running down through the lateral part of the brainstem. But as we've indicated, what localizes the lesion to various parts of the brainstem will be what cranial nerve will also be lesioned along with the long tract signs. And certainly, like any nerve lesion, cranial nerve deficits are always ipsilateral to the lesion and localize the lesion depending on the exit or entry point of the nerve to the midbrain, the pons, or the medulla. Now, what's going to be different, if anything, if we lesion a long neural system component above the brainstem, either in parts of the thalamus, the internal capsule, or even at cortical levels as illustrated here? With regard to the long tract signs, there's not going to be any change. In other words, a lesion of motor cortex or somatosensory cortex where the neurons are found that give rise to the corticospinal tract, or in cortical areas that are sites of termination of our body sensory systems, the long tract signs will still, in the limbs and body, all be contralateral. What's different will be what we'll see in the cranial nerve territory. If we lesion trigeminal somatosensory cortex, since that's at the end of a 3-neuron crossed pathway, we're going to see a contralateral facial anesthesia that's likely to be complete if we lesion all of trigeminal somatosensory cortex. And if we lesion all of the corticobulbar fibers on a corresponding side, again, we're likely to see just a contralateral lower face weakness. So the bottom line is, when we move above the brainstem, either in the internal capsule or at higher levels of the thalamus or cortex, all of our long neural systems, signs and symptoms in the limbs and body will be contralateral, as will any deficit that's seen in the cranial nerve territories when we lesion trigeminal sensory cortex or the corticobulbar neurons in motor cortex. We'll see either a complete anesthesia of the face or just lower face weakness.